Hi everyone. I I hope you can see me in the slide. I actually can't see anyone else. I see Kristen Majarian who is here with me. I hope that you are able to see her. She is part of CalMap and she does the case management and also does everything else that's related to CalMap uh, in the Orange County area. So if you need to contact CalMap for any reason, Kristen would be one of the persons that you can do it if you're in Orange County here. Kristen, do you want to say anything?
I'll just introduce myself real quick. I am a social worker at Children's Hospital of Orange County. Several months ago, back in July, Chalk partnered with CalMap to provide more localized care coordination and psychiatry consultation down in South County. So I interact with a lot of pediatricians from the Orange County and Chalk Hospital for the care coordination piece, as well as in other parts of the state. And I'm here. I will be just listening along with Dr. Nguyen, but certainly facilitating any questions or comments in the chat as well.
I forgot to introduce myself. My name is Wayne Nguyen. I'm the chief of psychiatry at Chalk Children's, or now it's Rady's Children's Health at Orange. I am doing this as a part of a CalMap presentation, and I just want to make sure that I acknowledge Lauren Hack, James McCracken, and Joan June as the materials that I have obtained from for this presentation. Um, Let's see. I have no financial disclosure. This session is supported by the HRSA federal grant funding and the California Department of Healthcare through Prop 56 in partnership with Anthem and Blue Cross. And so my goal today is to present some practical evidence-based strategies for identifying and managing disruptive behaviors, disorders in children and adolescents. If you ever want to connect to CalMap, we offer free, timely, personalized consultations for clinicians Monday through Friday, 8:30 to 4:30. And you can scan the QR code here or call the support line there if you need to contact. So the objectives today is to recognize disruptive and problematic behaviors in children and adolescents and being able to kind of differentiate normal development from true development, provide some behavioral management guidance and resource to parents. I'm hoping that I can provide some behavioral management tips that you can use in your office while the parents are there. Describe psychosocial treatments for disruptive behavior disorders and maybe some of the medications that can be used in the treatment of disruptive behaviors and when they should be used. So the first thing is, what do we mean by disruptive behaviors? It can be, all the way from mild defiance to aggressive and destructive acts. So the key to determine whether a behavior is developmental appropriate for the child's age and situation. That's the main key to see if it's something that we need to treat, because a toddler's tantrum when he or she doesn't get a toy is normal. But if you have that outburst in a 10-year-old at home and school, then it's no longer typical. So you got to make sure that whether the behavior is appropriate for the developmental stage that they're in, the frequency, how often does the behavior occurs, and then the intensity, how severe it is. The crying versus the hitting or the banging heads, and then the pervasiveness across setting. Does it just happen in one place or the other? You can use like rating scales like Connors or Vanderbilt to kind of make sure that there's some consistency to what you're doing. But it's not the behavior itself that's the diagnosis, but it's more of the pattern and the impact on function that we're looking at right now. So what is disruptive behavior disorder? So we're going to review the main DSM-5 TR diagnosis here. So first up is oppositional defiant disorder or ODD. So these are the kids that are angry, argumentative, and vindictive. And the behaviors have to occur for at least 6 months. And these are the kids that usually argue with authority figures and they kind of annoy other people also. So conduct disorders, on the other hand, is much more severe. It's a violation of social norms and others' rights. So these are the kids who are lying, stealing, being aggressive, or they are destroying properties. And these are lasting for at least 1 year. So these are the mean kids here. And then there's the intermittent explosive disorder or IED. And this is where you have recurrent outbursts of aggression, either physical or verbal, with property damage or physical assault. And you got to have at least three in the past 12 months. And this is often, a diagnose that people use when they don't know why the behavior is occurring, but that there is a behavior and it's severe enough to come into attention. And then there's the other when you don't have the full criteria. And DMDD, on the other hand, is disruptive mood dysregulation disorder, and it involves chronic irritability, severe temper outbursts. So it's sort of like a mood-based version of like chronic dysregulation. So you have both, not just the behavior, but also a lot of poor mood. And we always want to think about ADHD, depression, bipolar anxiety, PTSD, and trauma because misdiagnosis is a real concern. So, someone or a child with trauma may look very oppositional and defiant when they're really just being hypervigilant or being very fearful. So before labeling somebody or someone as defiant, we like to look at see what is driving the behavior rather than just looking at the behavior and diagnosing that by itself. So before we do anything, we always want to make sure that we do some safety check. And it always include a safety components for both the child and other people. So, is there any neglect or abuse that's happening, any substance abuse, any danger to others you wanted to explore, sort of like the temperament of the kid on how they have been ongoing since they were younger, whether they are always someone who is shy or someone who is always kind of like explosive or defiant. And then parent-child dynamics, how are the interactions between the parents and the child, and then any trauma history. ASD or developmental delay is something that we always want to make sure that we um, want to consider. Family, like in sort of like the family child dynamics, if you want to look at family conflict or the way that it's discipline and things like that, because they all can exacerbate disruptive behaviors. The first thing in treating disruptive behavior disorders is that you have to engage the parents because um, the parents are the one that's really doing the work for you. Even if you are the therapist, it's you're working through the parents and you're not doing it directly since you're not doing it you're not being with the parents all the time. And so you got to address the parents resistant. It's not really the oppositional defiant parent, but it's more the idea that they feel like they're being blamed, or it's the part where it's that you hear a lot. I hear a lot of it's I tried that already. It doesn't work. Why do we doing the same thing over and over, or it's not worth it. So you kind of have to validate the parents and recognize that this is difficult work. And sometimes I would even ask to say, if do you have the energy and the enough energy to do this? Because it's not easy to do this. And like I mentioned before, parent intervention works better than child level intervention. And you want to remind that, hey, you know what, this isn't working very well right now. So if you want to stay in the same place, it's not good, but that it actually would cause you even further problem in the future. So addressing it right now while it's hard work, it actually pays off rather than waiting. Um, and what we usually use as a framework for parents to deal with is the ABC model. So there's the antecedent, the behavior, and the consequence. And so the first thing is the antecedent is what happens before the behavior. Maybe the mom is saying no here, or the child is facing a transition, and then behavior B is the actual behavior. The child, the scream, the throwing, the fit, and then the consequent is what happens after. So, what is going to happen to the child after they have the behavior? Do they get what they want? Is the parents withdrawing? And it's the consequence and the behavior of the parents here that either reinforce the cycle or decrease the cycle. Okay, if the mom calms down the child and promise to buy the toy here, both the child and the parents are negatively reinforced, meaning the behavior is going to increase from both the parents and the child because the child gets the toy and the parents avoid the tantrum. So once we understand, the function of the behavior, then we can design the intervention for it. Because, the idea is what is behind the behavior, and it's used for communication, there's some goal and benefit, and maybe there's no function from it. And then you want to look at other reasons on why there is such behavior here. Uh, the most behavioral training for parents is the most effective first line intervention for any type of disruptive behavior disorders. It's not medication. And the idea behind this is there's something called a functional behavior analysis, which let's see, and you analyze the behavior to see why it's occurring. You look at, the ABC of why. And here is the two parts. One is we want to increase the positive behaviors. And so usually praise or attention or something like that, or some sort of a reward tokens that is immediate and consistent is very helpful. And then the other is to decrease the behavior. So one is increase the positive behaviors, but the other part that we can do is decrease the negative behaviors. And some of that is plan, ignoring, timeout, or losing privileges. And some of these things, you kind of discuss it with the family or the parents while you're in the office there. It's very easy. You can do this with you can even do this with your spouse or significant others. If you want to increase a positive behavior, you can always say, "Hey, you know what? The you smell really good today. What are you using?" And I imagine that they will use it again. And if if they're yelling and screaming and why don't I have my dinner ready or something, you can just walk out and say, you know what, you're not gonna get to go out with your friend the next day, and that will decrease the behavior too. So, these types of things are not only useful for patients, but just for everyday life, even with your colleagues here. So the idea is you give children or whoever that you want to a lot of attention when they do something that you like, and then remove attention when when they're doing something that you don't like. And it works for everyone. So parents' behavior management training and family-based treatment. That the goals is to provide consistency, clarity, and celebration. These are the three things that we're going to talk a little bit more. And again, so that way you can use in your practice and, with the parents. If nothing else, how are you doing as far as being consistent in the way that you communicate and discipline? And the idea of all of these things is that it provides psychoeducation, improve the interaction cycles, and helping the parents to establish clear expectation and consequences, and helping parents and youth to have problem solving and effective communication strategies. So that the whole things of there's many different types of parents behavioral management training and family-based treatments, but that's usually the goals for all of these different types of training. So some of these are that I don't know, maybe you're familiar with. It's the triple BP, the incredible years, Barclay's method, Caston methods, 1, 2, 3 magic, PCIT for younger kids. For older kids, it's the family-based therapy or the multi-systemic therapy. So it sounds very you may be familiar with some of these things, and if you need more information about it, Kristen can provide resources in our community as far as like who's doing it. But so like for instance, Triple P is the positive parenting program, and it emphasizes like more about positive reinforcement and relationship buildings. And the Incredible Years is on structured routines and emotional coaching. And then PCIT is the parent child interaction therapy, and it just is uses real-time coaching to shape interaction. So basically they're in together, and there is a coach, a therapist or someone like that who is and the parents would be they have a little earphone or something like that, and the coach would be working with them to kind of work through a situation with the parents and coaching the parents on how to handle the child. So PCIT, there are multiple places in Orange County that does this. Um, I'm not gonna go through this. So, so this is sort of like the core, structure here. It's consistency, clarity, and celebration. So consistency is there's time and communication strategies. And so with clarity, you're talking about clear instructions and routines, clarity about consequences for misbehavior, and then also about stress and emotional regulation. So celebration, rewards, right? Incentives for doing the right thing. Uh, you show up to work, you get paid. It's a reward, and you keep showing up again. And then label praise, meaning like you don't just say a good job, but then you say, very specifically, what is it that they are doing good? Like, for instance, good job finishing your meal, or, thank you for putting your toys in the toy box, rather than just, oh, you're doing a good job. Because it increases the behavior when you can be more specific in what you're saying. So the first thing is consistency. So again, I'm just sort of like reminding you of a lot of things that you're doing already and that you can do with any patients, and regardless, if they have a diagnosis or not here. So the first thing is that the only tool that you have with your child is your relationship with them, especially as they grow older. You can't do physical containment. You can't force them to do. And when you have a teenage child, the main thing that will affect them is, how your relationship with them is going to help them to be able to be willing to listen to you. And if you have adult children, that's the only thing. Okay. So what do you have to do to maintain special time here? What you're trying to do is deposit money into the positive bank here. So you want to have some schedule and sacred non-contingency, meaning like that it doesn't depend on anything. Okay. You don't have to be good to get this, good or bad. You're going to get time, that we spend together. Okay. Uninterrupted, parental attention, 10 to 15 minutes a day, and the child chooses and leads the activity. And that's the part that is important is that so that way there's no conflict. We don't want to do a time where you and your child are arguing about what you're going to do. It's more that you're just going to do something that they are going to enjoy and you're joining in and you're listening and you are allowing them to lead the conversation, and you kind of just have to ignore if there's any misbehavior, especially if they're minor. Okay, special time. Okay. uh, and consistency in communication strategies. Okay. You want to give some, got to have frequent and open communication, independent support, and then, yeah, reflect, empathize, and validate, just trying to see if you are in your child's shoes, what would you do? So, give some choices, be firm, be empathetic if they are angry or upset. It's always good to have some sense of humor. Okay, humor is very useful to deflect a lot of things, and it just kind of help to distract them also. Take a step back, see the bigger picture, and ignore. Okay, plan ignoring. If you don't respond, then it's hard to argue or negotiate. Okay, because if you engage with them, that's the worst thing is then it keeps going. Second thing is clarity. So, you know, uh, you gotta talk about what you're gonna have them to be doing. You have to have reasonable and achievable expectation, and I think that's the part where I have to negotiate with the parents is that you can't just expect them to be able to do something right away, and because it's just not gonna happen. And so the parents have to be reasonable. Sometimes I say, let's talk to the child. Maybe you and the child can discuss about what is the outcome or what the contract is about or what you want to do, but both of them have to be reasonable. For younger kids, visual reminders is very useful, for especially for certain routines that are needed to be expected to be done everything every day, like brushing your teeth, putting your clothes on. It's a visual schedule is very nice. And you want to have them in a place where they can be easily seen. The bathroom is a good place. The bathroom mirror is a good place for them because they always look in the bathroom or in front of the toilet also. First thing in the morning, most kids are using the toilet or the bathroom. And so if you can put a little visual schedule or just a schedule of written things if they're older, just for them to do. And then praise and rewards are always useful, even for adults, little praise, little rewards, and people will go a long way. Celebration, like we said before, and we want to make sure that we are very specific in what we say, and the goal that they always say is five positive things for one negative things, and then privileges and choices, and it doesn't have to be something expensive. It could be time with video games, little younger kids, it's extra bedtime story, and you can use like little rewards daily, and then you can add like, oh, if you're able to do five of these things, then you get a bigger thing, so that way they are trying to get the whole week of something that's bigger. But reward is important, is that it has to be something that they really like and enjoy. You can't reward them like, oh, you know what, you get to take out the trash if you are able to, do your homework every day. That will not incentivize anybody to do something. It has to be something that they really want and enjoy. And so that's why even in your special time with your with the kid, it has to be something that, they enjoy. It can't be just, oh, it's what mom or dad enjoy. It has to be something that they enjoy. So I put some list of rewards idea here, favorite snack or meal, phone time, cooking, baking, dress parents up, living room picnic, all of those different things. So, and you can't use the same reward all the time because, the value of the reward goes down when it becomes so routine. So mixing things up, changing things up are always helpful. Any questions? I can't see anybody, so I'm just talking to, the screen and myself at this time. And when you begin a reward, I think everybody knows this, is that it's gonna get worse before it gets better. And what we're looking here is the extinction burst, right? So they're doing good, 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 good. And then boom, before they get good, it's gonna be a lot of behaviors before the behavior goes down. It's easy. The way to think about this is like in the old days, for instance, you know, um, if you buy a soda and the machine doesn't work, what do you do? Well, you bang on the machine, right? Because something may come out, okay? And if something comes out, then what you do is that the next time you're gonna bang harder, okay, until something happens. And so actually, the Coke machines, they make it so that way it's impossible to move it and to do physically anything to it to get something, because they know if they give up in the middle of a behavioral treatment, in this case, if in some ways, if the people bang hard enough and they get something, it's gonna get worse the next time, because they know that the people are going to try harder, shake the machine, throw it down or whatever to get something. And then it's in the same way. If you're trying to stop a behavior, uh you have to be consistent, because if you give in, it's gonna get worse. That's what I tell my parents. Are you ready to do this yet? Because if you don't have the energy and you decide to give in the middle, next time it's gonna be worse. So you gotta prepare the parents, for parents training or anything else, is that, yeah, you gotta make sure that you have enough energy, time, and emotional reserve to do this, because you're gonna have to outlast your kid. That's the basic thing. As far as medications, again, they're all off-label usage here. We have stimulants, alpha-2 agonists, atomoxetine, anticonvulsants like Depakote, and then lithium and the atypical antipsychotics, some antidepressants also. So none of these, again, are first choice in these disruptive behavior, but they can be useful. Okay. So stimulants. I think this is, if you have to use, as far as uh, primary care or pediatrician, to use any types of medication, stimulants would be the ones that you would try and start. So it can be helpful for not only ADHD symptoms, but other symptoms outside of the core ADHD. And if the ADHD is responsive to this type of treatment, then the first thing to do is you gotta optimize the existing medication. Okay. And some of this has to do with the fact is that ADHD has comorbidities, and all of the other behaviors are part of this, and you don't know quite how it goes, but it is helpful, yeah, if you have this and ADHD. There's not a lot of studies on uh, stimulants and disruptive behaviors. Uh, ADHD usually kind of coexists. So, that's the reason why sometimes even if you treat um, the disruptive behavior, it's better because there's some ADHD in it. Let's see. So the hyperactivity is large, but again, impulsivity, aggression, compliance are very useful. So if you look at this, Concerta or methylphenidate, either one here has a pretty good effect size on as far as like in this case, it's the rule violations specifically. So it is very helpful. Uh, Physical aggression, like I mentioned, is very helpful. Uh, so even the teacher's rating to show that it is helpful. It's hard to see this in here. I'm sorry, my black, my green, and um, it didn't show up there. But what it basically said is that yes, it is helpful in ODD symptoms if you're using stimulants for not just ADHD symptoms. Atomoxetine, not as good as the stimulant, but can be helpful. And with atomoxetine, it has to do with actually more related to the dosing range, where the higher dose has a bigger effect than the lower dose. And so the higher dose is like 1.8 up to 1.8 milligram per kilogram. Alpha 2 agonist, again, is also helpful to as far as, reducing the ODD symptoms. Clonidine and methylphenidate, again, all improve with as far as the disruptive symptoms. Atypical antipsychotics. Now that's that's a kind of warm that we've been having to even the psychiatrists are doing it. There isn't a large studies to support all of that. Um, the conduct symptoms is helpful. The aggression is clinically significant. But as far as using this, I think that as a pediatrician, you wouldn't want to start something like this for behaviors just because there is actually long-term side effects and other effects on the child that we really don't know about as far as development and everything like that. So I think, if you are reaching for atypical antipsychotic, and I've seen mostly it's risperidone that's being used. You want to be careful, and if you need to use it, you want to use it in a very short term, months, rather than anything, because it's easy to keep the medication on just because they do a little bit better on the medication, especially with the aggression. Quetiapine is a medication, it's a type of antipsychotics, and in this particular study, it is useful, as far as the improvement here. And the dosing range is about 300 milligrams. So Seroquel, it's up to 800, and so it's in the middle somewhere. Uh, we're looking at this picture. It's the stimulants in blue, risperidone is in red, Depakote is in green, and then placebo is orange. And if you look at this, there is improvement with any of these medication in comparison to placebo. Lithium is another medication that we use. I would say that we use it in very severe cases. I have used it in children who are so aggressive, but usually it's not just that they are having only disruptive behaviors, but usually there is neural developmental disorders, autism, or um, also some cognitive difficulties rather than just, uh, the behavior. ADHD, these are some of the scales. We always want to use assessment. As far as assessing them, we want to use things that are consistent and things that we can look over times, because it's easy to say, hey, you know what, we haven't had any improvement, but it's hard to see the improvement over 5 months, 6 months when it's a gradual improvements. And if you have an objective scale that you're using, then it's much more useful. So SNAP, Connors are usually the something, and document the symptoms that you're seeing would be very useful, because you can always refer back to them and say, hey, or is he still hitting, his sister or her sister? And maybe they have gone to other symptoms, but at least, hey, you know what? They're not hitting anymore. They're still throwing things, but at least they're not hitting. Okay. So I just want to show briefly sort of like an algorithm for this. So if you have someone with a disruptive behavior, so not even diagnosis here, just a behavior. So you want to make sure that you do the safety check. First line treatment is parent management training, family-based therapy, CBT, play therapy, reward system. You monitor. If it's a severe case, you can add medication like for ADHD. An alpha agonist is reasonable, guanfacine or clonidine. If there's severe aggression, then atypical antipsychotic, and there's mood dysregulation, then mood stabilizer. Um, if they're doing well, then I would just continue with the psychosocial intervention, parent, family education, and resources. Always combine treatment is the best, and step five, and then reassess and adjust plan regularly here. So summary, DBDs, disruptive behavior disorders, are very common in parent conditions with long-term risk. So irritability in kids predict future depression, very high comorbid ADHD, behavior management therapies is the first line of treatment. Medications may be considered, but standard ADHD treatment is probably where we would want to start rather than an antipsychotic or mood stabilizers. And then you want to measure the impact of your intervention, so that way you can uh, look at your treatment choices, and then making sure that compliance and how it's ease of use for whatever they're doing, whether it's therapy or medication. I have a bunch of resources for the family here. Their books, and their websites. I think, what I can do is maybe have it available to Kristen, so that way, she can have it for the group here. And thank you for your attention. I am done.